Thanks again, Dr. James Barone, for joining me to talk about maintenance of certification for the American Board of Surgery in the U.S. Give me your 2 cents on maintenance of certification.
Well, I understand why it's necessary. I think that the board is trying to be proactive here. I think that the public and organizations representing patients and patient safety are demanding some sort of thing that would assure them that surgeons are competent, and that occurs much more often than the 10-year interval between written board examinations. I understand the need for this, and I think the board is trying hard to make it reasonable for surgeons, but there are some issues with it, and I'm not too sure what parts of it are worth it, and what could be done to make it better. And I will say, in the American Board of Surgery's defense, that it seems a lot less cumbersome and oppressive than, say, the American Board of Internal Medicine's exams, which I don't know if you are familiar with that, but they have more things to do and more frequent things to do than surgeons, and many of the internists are really up in arms about their process, so much so that splinter groups are forming and mass protests against this are being it isn't quite rallying in the streets, but certainly there is a lot of unrest about it. In the surgery, if you look at the rules for the surgery maintenance of certification, they are, I think, quite a bit less of a problem to deal with than the ones for internal medicine and the medicine subspecialties.
If you pick apart the elements of maintenance of certification, are there ones that stand out to you as good ones, and others that don't make sense? And
yes, I think there are a few, and it's a timely question. I just received in the mail, excuse me, the newsletter from the American Board of Surgery, and the major topic in the front page and beyond is maintenance of certification. So some of the things are quite obvious, like maintaining your license and hospital privileges, and references from chairman of surgery and things like that, and credentials committees. Those are vital things, because I think that the people where a surgeon works know if he's any good or not, and I think that they are absolutely essential parts of the process. You need recommendations, or at least information from them. And the CME requirements are, I guess, fairly reasonable, because it's not too much. Frankly, it's only 30, if I read this correctly, it's only 30 hours a year. And 2/3 of it needs to be some kind of assessed with a test or some other way of assessing, which I think is a step forward, because let's face it, you can go to some CMEs and you sign in and you can read the paper and then you can leave, and it doesn't mean that you've learned anything. And at least if there's an examination, there's some value to it, although you have to be a little bit careful about that too, because some of the things are just, some of the quality of some of these CME courses just isn't that good. And of course, retaking the boards is important. And again, it gets to the question, though, of is passing a written examination really, does that mean you're a competent surgeon? And I don't think it necessarily does say so. One of the ones that's a little bit troublesome is the idea that the board has, and I'll read it here: ongoing participation in a local, regional, or national outcomes registry or quality assessment program. When I participate in these things, let me give you the analogy. It's analogous to your hospital's infection control program asking you to report wound infections to them, because, of course, they have no way of knowing, once the patient's at the hospital, whether somebody got a wound infection. And so I think that if you look at rates of wound infections that are reported that way, it's really quite low. and not realistic even. And so you wonder, what is the point of participating in a local or regional registry where you are self-reporting your complications? Now, some people, I'm sure, are quite diligent about reporting all their complications, but others may not be. And I have never seen any data from any of these registries about what the compliance rate is, or even, I'd like to see a paper where somebody says, hey, we looked at this registry here, and the complication rates are pretty low, and we're a little suspicious that maybe this isn't the best way to do this. But on the other hand, I don't know what is the best way. Now, I understand that the National Surgical Quality Improvement Project is one of the registries that is acceptable, but my understanding is they only take samples of data. They don't take every case and report it to the National Registry. So, and again, some of that is going to be based on self-reporting, like wound infections. If somebody goes home the day after a gallbladder operation and gets a wound infection a week later, it's up to the surgeon to report it to the NSQIP person. I don't know how that works. So,
even if the numbers even if the numbers are not accurate, maybe there's the benefit of measuring. What's the word for the effect of getting improvement simply by
it's
measuring?
The Hawthorne effect.
Yeah, the Hawthorne effect.
Yeah. Tell people you're watching, and they'll get better, and that's very well known and very true. It isn't quite the same amount of watching as you do with some other. Like if you, for example, tell people in the ICU, as of next week, we're going to start monitoring hand washing. No matter what program you put into effect, the hand washing is going to be better. But this is watching from a distance, and I'm not sure how effective a registry really is. So the question then would be, does it matter? Is this going to satisfy the public and the patient safety advocates that we're doing something, or are we really trying to assess maintenance of certification and competence? And I don't know what, in other words, are we going through the motions here and say, look, we have this multi-step thing here that everybody has to do, and, is that good enough? Or are we really trying to do something which I don't know for sure that it's going to be all that effective? Because, I would like to know, this has been going on for a while now, what effect has this had? Do we really know that people who do this are really maintaining their competency, or are they able to just do this? Because honestly, I think that you could probably get, if you just were diligent and checked all the boxes here and did everything that was asked of you, then you would be, quote, maintaining your certification and competent. But are you really? Does this prove that people are competent? I don't see that exactly coming out the same way. In other words, I tick off all the things that need to be done on this maintenance of certification. Therefore, I'm competent. I'm not sure.
Yeah,
about that.
How do you think incompetence usually comes to light?
Well, it usually comes to light,
paper,
I think.
If you look in the paper, it's through the legal system.
It comes. Well, it's not always the legal system. I think it comes to light. That's one way, but it also comes to light where people begin to notice that somebody's having a lot of complications or problems, or is a behavioral problem or whatever. But it takes forever to get something done. When you complain to your hospital's, say, risk management people or medical board or executive committee or whoever runs the show, it's hard to discipline doctors. I was a chairman of surgery for almost 24 years, and I can tell you that it wasn't hard to identify guys who weren't doing very well. It was very hard to get rid of them, though, because the same lawyers who will tell you that they are the policemen of the medical profession, and thank God we have malpractice insurance and malpractice lawyers to help regulate medicine. Those are the same guys who will defend an incompetent person to the nth degree and keep him in practice for years beyond when he shouldn't have been. So that is another difficult area, because I think everyone kind of knows when somebody's having problems, but there's a extremely large gulf between knowing that and then getting effectively doing something. And I think we still do things like nudge somebody out of the way and get them off the hospital staff, and then when they apply for privileges somewhere else, you really can't say negative things about them because, again, the lawyers will say, you know, I'm going to sue you for libel because you said this guy wasn't any good. So you play the game that human resources people tell you to play, which is you just say, well, he worked here for 6 years, and that's it, you know.
And now he's somebody else's problem.
And it's called damning with faint praise, but it's still a problem. Mm-hmm. And I think those things, you know, I don't know if you know the story about this neurosurgeon in Texas who went down there after a residency program and cut a swath of destruction through the Dallas suburbs and had many complications. And as soon as he got there were people who were assisting him in surgery who identified that he was not technically competent and that he had very poor judgment both in and out of the OR. And there are stories about he had to be restrained by the nursing staff at the OR table from doing something crazy on the table. And the Texas Medical Board got wind of this because general surgeons who were helping him with spine cases with exposure were notifying the medical board that the guy wasn't competent. And it took them 2 or 3 years to finally stop the guy. And meanwhile, he had some deaths and some, you know, really terrible complications. And if you can't stop a guy like that, then the subtle things like, oh, you know, this guy has a lot more wound infections than anyone else, or seems to have more, you know, that's going to take forever to do. And I really don't see maintenance of certification helping to identify those people or help to, you know, change them or whatever. It's very difficult to do. So I'm not, you know, again, I think you have to look at the maintenance of certification and say, what is the goal of this? Is it to say we're doing it, or are we really trying to do something? And because, I mean, look at this. If you look at this, for example, I'm looking at it. Let's say that the chairman of surgery at somebody's hospital reports to the board that the guy's not very good. Let's just say he just says that. Well, first of all, he's risking getting sued. And secondly, what's the board going to do about it? What is there? They have no power. Well, but testing.
There's no mechanism.
Testing, the guy may be able to pass a test. The test isn't the issue. So I just don't see how that's going to really solve our problem that we have with the public and the patient safety advocates is our own credibility. In other words, are we policing the profession? No, they don't think we are. And the fact is we don't do it very well. And there are impediments, like I said, because the lawyers on one hand are claiming they're policing the profession, and on the other hand, they stop you from ever disciplining a doctor. Mm-hmm. You can't do it. Like I just read of a case where a doctor was his privileges were revoked for being a bully, and there were several anecdotes in the story that I read that the guy was a bully. He was, you know, bullying the nurses, bullying everybody, and he, after he lost his privileges, of course, retained a lawyer, and the lawyer is suing the hospital because they didn't go through the exact right process for doing it, that he wasn't any worse than anyone else. You know, it goes through you can name all the things that the guy would probably say. And I'd say he's got a 50-50 chance of getting his privileges back, plus probably get some money out of it. So how do you discipline doctors then? You know, because that's a huge deterrent. Then the next time that comes up, anyone who's read that story is going to say, man, I don't want to get into that. I'll just let this go. And that's how bullies can work in a place for 20 years, because they're bullies and they cower everyone. You know, that's how it works. So even that sort of thing, which honestly, bullies aren't necessarily detrimental to patient safety, although they can make the staff nervous. And when I saw bullies in the operating room, I always worried that the nursing staff was going to make mistakes because they were so afraid to get yelled at that they were going to change their own behavior. So I think it can be intimidating and not good for patients. But on most of the time, it's just not happy time for the staff to work with bullies. But it is extremely difficult to get rid of people like that. And by the way, other than a note from the chief of surgery or chairman of the credentials committee, there's no way that the maintenance of certification is going to pick up a bully. Not good. The process has no way of doing that. And again, what is the American Board of Surgery going to do if they hear that Surgeon X is a bully?
Right.
What is are they going to revoke his board certification? I don't think they're going to be able to do that, because guess what? They'll get sued too. So they don't want to be sued. Nobody wants to be sued. It's a very annoying thing. So I don't see
self-regulating is difficult.
How really? Yes, and there's a lot of it's difficult for the medical profession to regulate itself, and it's difficult to even self-regulate yourself, because I know that when I would get these things in the mail about a wound infection, like every month, the last place I worked, every month I got a form from the infection control people. Here's the cases you did for the month. Who got a wound infection? I get 15 gallbladders on there. I don't remember who got a wound infection, and it's difficult to, and and by the way, it wasn't the day after that month. The December's came in March. So 3 months had elapsed between all the cases you did in December and now, and you don't deliberately want to, conceal your wound infections, but you just don't remember after you do so many cases. Right. You don't realize that you're not. It's not uppermost in your mind, and you're not keeping a separate record of it, maybe on your own. And it's human nature. You just forget things. And then there may be people who don't. You just say, look, I'm not going to tell these people if I ever got a wound infection, because it could be used against me. And the last person I'm going to tell is the hospital, that can say, well, you have more wound infections than anyone else. You're out. So, there's a disincentive for that kind of self-regulation. Sure. And frankly, that is the problem with being in a national registry or a local registry as well. And that is, you want me to report my anastomotic leaks? Wait a minute. If you can tell me that everybody else is honestly reporting all their anastomotic leaks, that's one thing, but you can't. There's no way. So, I mean, it's my cynical nature, I guess, is that I just don't believe that these sorts of things are really effective at identifying who is competent and who isn't. But I don't know how you do it unless you had a nurse go out to everybody's office hours and look at the patients while they came in and said, this infection. It's very hard to do that. Yeah. So that's why I brought up in the very beginning of this session that there were some, you asked me what things that I think weren't that effective, and that to me is one of them. The registry thing is just, I think, not an effective way to determine maintenance of competence or certification. So, that's, but again, my problem is you ask me, okay, you don't think that's very good. Well, what would you do? I don't know.
Right.
I don't know. I would like to make the patient safety people happy, and I would like to make the patients happy, and I would like to assure the general public that we do a good job and that we don't have incompetent people operating on patients. But I don't know how to make that happen. I think as long as there are lawyers who are willing to defend these people to the extent that they possibly can, and it is part of the American system that you're able to retain a lawyer when you're threatened. You can't say, well, you just can't let doctors sue if they get kicked off staff, because on the other hand, there are certainly cases where politics of hospitals have gotten people into situations where they may be threatened with staff dismissal, and it's only because they compete with the powerful political figures on the hospital staff. So I understand that. I'm not stupid. I understand that there can be malicious activity in the other direction too, sure, where it's not somebody is drummed out of the Corps because the most powerful surgeon in the hospital doesn't like the guy and decides that he will align some forces and get this guy kicked off the staff. So you got to be able to have a lawyer in that kind of situation.
Hospital politics. Sounds like another good topic for another day.
You don't have enough time for me to go into that. It's a lot of that.
Well, thanks again for talking to us. Appreciate your 2 cents.
Thank you. Pleasure. Thank you.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.